Welcome, my name is Lauren Johnson. I will be discussing inequities facing overweight and obese Australians in rural and remote regions and outlining how a public health approach can combat these with intent to reduce obesity rates within these populations. Obesity, simply, results from the repeated overconsumption of excess energy and is exacerbated by a sedentary lifestyle. However, obesity has also been described as complex and multifactorial and, most importantly, preventable. Obesity is not experienced equally within high-income countries. Those of lower socioeconomic status are more likely to be overweight or obese. In 2017, the Australian Institute of Health and Welfare outlined between 2014 and 2015, 69% of Australians living in rural or remote regions were overweight or obese, compared to 61% in urban areas. 30% of Australians live in remote or rural regions. When we use terms such as rural or remote, we think small. However, of the 30% of Australians living in these areas, 20% are spread across 1,500 communities containing populations of 5,000 or less and combined have a population the size of Sydney. Within Australia and many developed countries, socioeconomic status declines with remoteness. There are numerous intertwined social, economic and environmental determinants of health that contribute to higher rates of overweight and obesity within rural and remote populations. In comparison to urban areas of Australia, remote and rural regions have limited access to primary health care, education, high-speed broadband, transport and basic infrastructures. The limitation of accessibility to services, facilities and infrastructures results in increased prices of basic resources such as petrol and groceries. Median gross household incomes are lower in rural and remote areas, and unemployment rates increased. It should also be noted that while rural regions are likely experiencing limited access to particular services, remote regions may be experiencing no access at all. Some notable health inequities faced by overweight and obese individuals within rural and remote regions include food insecurity, grossly expensive food items, limited availability of healthcare services, and the gap experienced by Indigenous Australians. Recalling that 30% of the population is living rurally or remotely, this is a vast number of Australians that are disadvantaged predominantly due to geographic location and is highly inequitable. Increased rates of obesity found in rural and remote regions of Australia highlights inequities within the country's delivery of social, economic and environmental policies and provision of funding to healthcare, education and infrastructures. Not only does socioeconomic status decrease with remoteness, but items of basic living are less accessible and often more expensive in comparison to urban regions of Australia, making healthy eating, healthcare, and a healthier lifestyle less attainable. This then fuels obesogenic environments within these communities, as less healthy, highly palatable foods are then more readily purchased as they are often cheaper. Rural and remote areas are also more susceptible to food insecurity, which has been linked with increased obesity levels, likely due to unhealthy foods generally being less perishable. Research findings from Healthy Basket surveys found that food prices increased significantly from major cities to remote and rural towns, with the average basket costing 23.5% more in remote Western Australia than the same basket purchased in Perth, 49% more in remote Northern Territory than in Darwin, and 31% more in very remote towns of Queensland than in Brisbane. This disproportionate cost of food in rural and remote areas is predominantly due to the transportation and refrigeration of foods, and food insecurity is fueled by irregular deliveries. To understand what drives obesogenic environments and thus populations with higher rates of obesity, we may consider what is required for healthy eating to occur. In 2017, Friel and others created the Healthy and Equitable Eating Diagram to depict healthy eating as a complex adaptive system. This is a simplified version of the diagram consisting of 7 subsystems: food supply and environment, transport, housing and the built environment, employment, social protection, health literacy, and food preferences. The diagram provides us with an insight into the highly complex interaction of factors that contribute to healthy eating and thus allow us to consider the inequities that are present within rural and remote populations that combine to cause a breakdown of healthy eating and the growth of overweight and obese individuals. Healthcare accessibility is limited for those that are overweight or obese living in rural and remote areas. GPs take on the majority of responsibility for weight management and prevention within these communities, and multidisciplinary teams are often not present or too far to access via transport. In 2017, the Australian Institute of Health and Welfare outlined that the number of medical practitioners and specialists in total per 100,000 was 253 in remote areas, compared to 409 in major cities, and the services provided by GPs in very remote areas was half of those that are provided in major cities. Rural and remote areas have higher populations of Aboriginal and Torres Strait Islanders than in major cities, with 45% of those living in very remote areas being Indigenous Australians. It was reported in 2017 by the Australian Bureau of Statistics that 69% of Indigenous Australian adults are overweight or obese, in comparison to 63% of the remaining population. The inequitable gap between Indigenous and non-Indigenous Australians is well documented, and the socio-economic difficulties they face, along with alienation, loss of culture, and psychological distress, have been highlighted as drivers behind their increased rates of obesity. To reduce rates of overweight and obesity within remote and rural regions of Australia, the socio-economic inequalities and inequities must be addressed. Incidences within communities will not be mitigated by a single cause and effect solution provided by a healthcare professional, such as exercise prescription or diet alteration, as this fails to consider the systemic contributors to obesity. In 2018, Stevens, Egger and Morgan stated, individual health practitioners are generally not able to alter the socio-political and socio-economic factors that are considered to be significant drivers in the rise in overweight and obesity. A public health approach will utilise research and resources such as systems thinking to understand the complexity of the causes and how each of these influence and feed into one another. Medical and health services play a key role within a public health approach, but alone cannot have the same reach as a strategy that considers all contributing factors and their interactions. As suggested by Baum within the New Public Health in 2015, a public health approach to combat overweight and obesity in rural and remote regions of Australia must incorporate strategies that are international, national, regional and local. This can be achieved by ensuring trade agreements do not restrict local production or the Australian government's ability to prioritise healthy diets, as well as placing restrictions upon imports. In 2018, the National Rural Health Alliance recommended Australia adopt a national obesity prevention strategy as a matter of urgency, with aim to reduce inequalities and inequities for Indigenous Australians and those living in remote areas. Action from the Australian Government to implement tax upon highly palatable, low nutrient dense foods and introduction of subsidies to basic healthy foods and their transportation will encourage equitable food prices countrywide. Further funding is required for state programs such as the Obesity Prevention and Lifestyle Program, so that they may be implemented into rural and remote towns of Australia, particularly those with high Aboriginal and Torres Strait Islander populations, where they are most needed. Adapting these programs so that they are culturally appropriate for Indigenous Australians and operated by fellow peers will also contribute to more favourable health outcomes. Local initiatives such as community gardens will encourage the production and consumption of healthy foods that are sustainable and local, and also strengthen community relationships. Local governments must liaise with state governments to improve the transport of rural and remote communities so that local shops, healthcare and other facilities are more accessible for their communities. Healthy canteens at schools, hospitals and childcare centres will encourage and normalise healthier options. Finally, further research into what basic primary health services must be available to all Australians is required, so that services may be more consistently and efficiently placed and the healthcare inequity of rural and remote areas addressed. Tackling obesity within rural and remote regions must have a shift away from cause and effect models that look for linear change, as commonly seen from a medical or health services approach, to a consideration of all factors within a system and how each of these drive change. As the National Preventative Task Force stated in their Preventative Health Strategy in 2009, the healthy choice must be physically, financially and socially the easier and more desirable choice than the less easy option. Thank you.